The last person that's going to come up is John Hackett from Abbott. One of the things that John worked on was some of the first instant tests available for HIV. And if any of you who've been around in the developing world and have seen what HIV testing used to look like, you'll appreciate how important it has been to actually have something that can do a rapid test. I mean, one of the biggest problems we have on this and many other diseases is getting people to come back for their diagnosis. And a key challenge remaining with HIV is that most people who are infected with the virus still don't know it. And so losing patients, having a test where they have to come back in a week or 2 weeks or even a couple hours means we've lost this golden opportunity to keep people into the care system. And so having something that allows a clinician, or in many cases, as Tom mentioned, a non-clinician, to be able to test somebody and to tell them within 10 minutes while you got them that they do or they don't have a particular disease is absolutely super critical. So John, thanks for your work on this. Thanks for Abbott's help.
All right, so my name is John Hackett. As I said, I'm the Director of Infectious Disease Research within Abbott Diagnostics. And I want to start, I'm sort of going to take a paradigm. I'm actually, rather than talking about point-of-care tests, we'll be talking about a laboratory-based test, which I guess to put it in perspective, Abbott is responsible for screening well over half the world's blood supply for serologic. It's probably 85 or 90% of the U.S. So we have a scope and, in essence, a responsibility in terms of, as we're developing these assays, to make sure that we create assays that can detect all of the variants, for example, and determine, was mentioned earlier. I mean, this test was actually designed to be in an African setting by the proteins that were included in it to allow us to detect divergent strains that are quite different than what we have here in the U.S. And as a matter of fact, taking you back, as Dr. Kenyon did, when you consider what it was like in the early 80s as we began to see HIV emerge. It didn't even have a name at that point. The time from when the virus was discovered and Abbott actually received material to start culturing, we had an FDA-approved test in 9 months. It was really, it's an amazing accomplishment. And to give you a sense of what diagnostics mean from a public health standpoint, if you were to go and get a blood transfusion in San Francisco in 1983, you had a 1 in 91 chance of being infected with HIV. After the launch of the first FDA-approved assay, that went to 1 in 40,000. With further development collectively by the diagnostic industry and improving these tests over time, went to 1 in 500,000, and then with the addition of molecular testing today is probably 1 in 3 million. I mean, it's an extraordinary success story, and the fear back then, I guess it's almost hard to imagine if you weren't there what it was like. Frankly, people were afraid to even go donate blood. I mean, there was that much of a misunderstanding. And yet, all of these years later, I mean, we've had amazing victories, and the mention of how many people are on treatment. Obviously, these people wouldn't be on treatment unless we had diagnostic assays which could identify them to begin with. And we're still left with HIV with, I think, some pretty sobering numbers. I mean, it's estimated now that probably 75 million people have been infected with HIV since the beginning of the epidemic. That's a staggering number. Today, there are 34 million living with HIV. And even with the rollout of drugs, I mean, based on 2011 numbers, 1.7 million people died. And what to me is frustrating, as I think about this, is there's 2.5 million new infections. So while we've reduced the incidence in some settings, we really haven't conquered the problem here. We're going to have a hard time treating our way out of this. If we look at, in terms of how many people are aware, 1 in 5 people, it's estimated, are aware that they're even infected. So obviously that creates opportunity for transmission. Diagnosed too late, what does that mean? Even in the US, somewhere around 40% of people who are identified with HIV are a year away from AIDS determining illness. So this is, again, cost to our healthcare system, morbidity for that patient. It in essence is a failure. And I'm going to sort of take you through diagnostics and some of the other areas related to implementation of diagnostics because it's a very complex issue. Even in the US, I think it's pretty amazing when CDC sort of ran these numbers and published this a couple of years back. that 50,000 new infections a year in the U.S. I mean, we could fill the average baseball stadium here with newly infected people. We stand today, it's more like 1.2 million currently infected and living with HIV in the U.S. And again, one of the CDC campaigns that, I'll leave you with, just think about it, that, one person is infected in the U.S. every 9.5 minutes. So while you're sitting in this session, think about how many people have become infected with this virus. So this is far from over in terms of what we need to do. But I do think there's hope, and one of the things I want to talk about is some of the new diagnostic tools we have to apply to this issue. So I want to describe to you what acute HIV infection is, because frankly, this is a relatively kind of new concept in the field. And what it is an appreciation for a phase of infection. So an individual's infected, where you start to produce virus, so nucleic acid can be detected in your blood, but you have not yet created antibodies to that virus. So our traditional assays look for antibodies. You can't detect what isn't there, and this is a problem. Now, during this period of time, you can have very mild, nonspecific symptoms: sore throat, rash, fever, mild lymphadenopathy. These can be confused with many other illnesses, flu and other things. So oftentimes, frankly, physicians miss that they have an individual in front of them who's at risk for being in this acute phase of infection. There's an enormously increased risk of transmission during this period of time. Obviously, the person doesn't know they're infected. They're producing loads of virus. Some of these acutely infected individuals have more than 10 million copies of virus per milliliter of blood. And that virus appears to be more infective, which biologically we don't have a complete understanding of why that is. The other thing we're beginning to appreciate is that this has a disproportionate contribution to the ongoing transmission of HIV. In a study in Quebec showed that less than 10% of their cases of HIV would be placed within this acute or very recent infection period, and yet it was responsible for more than half of transmissions. So if we're going to slow this down, we need to figure out how do we detect acute HIV. And certainly from a public health strategy, this has enormous implications. So I'll give one other paradigm. And again, this is the US I'm focusing on, and we have a pretty good health system, I think we all would feel. But here's the situation. When you look at individuals, the types of symptoms, they say 40 to 90% develop some symptoms early after infection. Actually, 50 to 90% of these people seek medical attention during that period, but they're not tested. And if they are tested, they're tested with an assay that detects antibody, which isn't present. So they would be a false negative and be told that they were negative. And I think this is astounding. When you look at numbers, and I've seen even from some states that it's even higher than this, but they say 50% of these patients have seen a medical care provider at least 3 times before they were ever actually tested and diagnosed as having HIV. More than 50% of ongoing transmissions are due to people that don't know their status. So this is an important issue. So what would be the benefits, both from the human's perspective as well as an economic perspective, if we could do a better job at this? Studies have shown we could reduce the hospitalization rate by roughly 63%. Incident morbidity by more than 27%. And again, this is because we detect so many people late, right? They're close to AIDS-defining illness or at that point. The cost reduction in terms of acute care over a lifetime, this is the estimated cost per individual for HIV care in the US. And I have to say, I've seen various numbers, and this is on the low end of those numbers. And finally, a very important study, the HPTN 052 clinical study, was a multinational study that showed that treatment of individuals with antiviral drugs can reduce transmission to their partners through sexual activity by 96%. I mean, this was astounding. It was in the news in 2011, New England Journal of Medicine paper that Mike Cohen and his colleagues published about the study. It's a tremendous opportunity, and again, we need to identify these people so that we can put them in a position where they're getting early treatment so we can prevent this ongoing transmission. So what I want to talk about is the new type of test mode that we have now available in the U.S. And I want to take you to the bottom point here. This is looking at what occurs in an individual after they're infected with HIV. So if a person was infected on day 0, about 8 to 10 days later, we start to see evidence of HIV RNA, so virus particles, in blood. And this ramps up very high. As I say, it could be millions of copies per mil very quickly. Now antibody, even IgM antibodies, the earliest type that's produced, don't really appear until about 3 to 4 weeks post-infection. Antigen parallels the RNA because antigen's present in the virus capsid, the virus particles themselves. And so we have the possibility, we obviously cannot detect antibodies in this window, so the assays that have been used traditionally here will not allow us to detect that an individual is infected. However, if we can combine detection of antigen as well as antibody, we have an opportunity to move in and deal with the acute phase and be able to detect these. Now, on the right, I pictured the Architect HIV antigen antibody combo assay. This is actually on an automated platform, Architect platform, that's a random access, high throughput instrument from Abbott. This was the very first assay of this type that was approved in the US. It was in June 2010. It was shown in studies with it that it can detect cases up to 20 days earlier than antibody-only tests. And I should say now, there are 2 other manufacturers. Bio-Rad has a laboratory-based combo assay available. It's 4th generation. You'll hear 2 terms for that. And Alair recently was approved for a point-of-care test, which detects both antigen and antibody. So I wanted to show, and I kind of apologize if you're not used to looking at data. I'm going to take you through one slide, and I think it shows some very important points. What this was is a study done with Dr. Mark Pandori at San Francisco Department of Public Health. And what they had been doing, in lieu of having a combo assay available, they have a high-risk population there. They knew had high incidence. So what they were doing is doing antibody-only tests, and then anyone who was negative, they would take those samples, pool them, these were small pools of about 10 each, and then run them on a molecular assay to say, is there viral RNA present? So this was their way of trying to gain access to acute infections. They realized they weren't doing well enough with the tools they were using. So we have 64 of these samples available to do this analysis as a collaboration. 35 of these samples fell into what we call the acute phase. Again, there's virus there, but there's no antibody. And what I'm showing along the bottom are various different assays. Now, 1st and 2nd generation assays, these were the earliest ones. They detect IgG antibody only. Western blot, I want to point out, this is what we currently use in our algorithm. This is the CDC recommended algorithm that was put out in 1989 for confirmation to show how insensitive it is and why we need to change. Some various rapid tests. All of these are 1st or 2nd generation formats. Then we move to other assays that are a 3rd gen. They detect IgG and IgM. So IgM gives you a little earlier detection. This is a laboratory-based test. And so in the blue bars are all of the tests that detect only antibody. Excuse me. The 4th gen Architect combo assay, you can see now, detected almost 90% of these samples. And you can see a dramatic difference between the ability to detect using an antibody-only test and the combination assay. Enormous difference. And the reason for this is, it's not that these tests are failing, it's there's no antibody there for them to detect. All right? These are acute cases that are being identified. So an important advancement as we think about going after acute infections. Now, what was being recognized in the field, and I really have to give Dr. Bernard Branson at CDC a lot of credit for even approaching this topic. It's been a challenging one. People get used to testing in certain ways, but what he and everybody else recognized is tests were getting more and more sensitive, and yet we were using an insensitive algorithm. So it was hard to even confirm samples that were seen positive on a third gen antibody assay. There's no potential for detecting acute infections. And even HIV 1 and 2, they estimate that HIV 2 was misclassified probably 60% of the time using the existing algorithm that we have today. So what was proposed in 2010 is using these combo assays as a very first step. Use the most sensitive tool you have. Go to a more rapid discrimination between HIV 1 and HIV 2, and then move to NAT. What this does is simplify. It reduces time to result. There are people today, even though this algorithm isn't out, who are starting to adopt it, and they can get results back to a patient, full confirmation, done in certainly under 24 hours and sometimes a day's time. This is an enormous benefit from a public health standpoint, because you identify someone who's acutely infected, you have an opportunity to counsel them, to help to try to change their behavior short term, and you also have an opportunity to try to find out what partners did they have. One of the aspects of these acute infections is oftentimes you find clusters, 3, 4, 5, 6 people infected very quickly from one acute infection. So I certainly, this has been proposed. We certainly hope soon that this algorithm will be formalized, because it would be a huge benefit from a public health perspective to have it. I want to just close by saying that these combo assays really do offer us an opportunity to improve over the numbers I showed you in the beginning. We can do better. We've developed better tools. Now we need to implement them. And certainly I think the combination of combo testing and the CDC algorithm will have many benefits. I do want to bring up a concept that actually Dr. Branson himself had raised, and that is we think about rapid tests as point of care. But again, when you have an instrument like these random access instruments, you actually can get a result in 29 minutes. I mean, this is why people are so excited. So in an emergency room, for example, in Arizona, a study that CDC published recently, they identified over the span of about a year and a half, testing essentially everyone that came into the emergency room who accepted the test, and they found 37 new HIV cases, 12 of those, so 32% were acute infections. I mean, how many more infections did they save? So it proved that the CDC algorithm will work, and it shows the benefit. And I just want to leave you, I don't think we can continue missing these. We need to do better. And certainly, we're trying to develop the tools and get them implemented now. I'll end on the CDC public thing, because, I mean, it is something to think about, and we really do need to slow this clock down to move through this. Thank you.